Hello, my name is Vladimira Mouravieva, and I'm Dr. Patel's nurse advocate. You are watching Dr. Patel's Optimizing Your Post-Operative Recovery class. Today, we will give you the tools to be successful in your recovery after surgery. We thank you again for letting us be a part of your care. The bulk of this presentation talks about the goal after surgery. You may have heard Dr. Patel use the words the trifecta. That encompasses three things: the patient being cancer-free after surgery, the patient regaining erectile function to preoperative status or as close to as possible, and regaining urinary continence. Those are in no particular order except for the first one. The number one goal for all of our patients is for them to be cancer-free after surgery. We will also cover what to expect after your surgery and hospital stay, and introduce the Global Robotics Institute. A good question that our patients have asked us is how will they know that they're on course to reach their recovery goals? We do expect our patients to follow up with either our office or their local urologist. We know we have patients from across the world, so it may not be feasible to come and see us. In that case, it will be important to follow up with your local urologist to make sure that the PSA is being checked in a timely manner and addressing any quality of life questions or concerns. Now, moving into the first topic of the trifecta, being cancer-free post-operatively. How do you know that you're cancer-free and remain that way? I'm sure all of you are familiar with the PSA. PSA stands for prostate-specific antigen. It is the protein that is produced by the prostate. Logically, if there's no more prostate, we should not be seeing a PSA. So post-operatively, the PSA should be undetectable or less than 0.1. Now, just for reference, patients who have a prostate, the normal threshold is 0.0 to 4. But please keep in mind that after surgery, we're looking for an undetectable PSA since you no longer have a prostate. What if your PSA rises after surgery? If your PSA rises above 0.2, reach out to your local urologist as well as our practice. What we'll do is look at the PSA doubling time. You cannot go off of just one PSA result, so you need several blood tests to assess the data and figure out if there's a pattern and what that pattern looks like. Something else that the physician may order is possible imaging, like a prostate-specific PET CT called the PSMA scan. This is subjective depending on what is going on with the PSA and what is going to help the provider and the patient figure out the best plan of care going forward. Now, I do think it's important to talk about recurrence. Regardless of what cancer one may have, whether it's lung, prostate, breast, unfortunately, there's no treatment modality that is 100% curative. However, certain treatment options work better for certain patients depending on the cancer, for example, patient's age, aggressiveness of cancer, and other comorbidities that the patient may have. Those are all factors that need to be taken into consideration. Now, the potential for recurrence is dependent on the final pathology that you will receive a catheter removal. Not only that, but the first PSA after surgery. Even with an unfavorable pathology, the first PSAs after surgery will be indicative of whether or not additional treatment is necessary. When Dr. Patel removes the prostate, a pathologist looks at the prostate under the microscope, and that is the detailed report that you will get at catheter removal. Now, recurrence occurs due to two potential reasons. There's a possibility of residual tissue that can produce a PSA later down the line after surgery. Also, a more aggressive Gleason score. Gleason score is how prostate cancer is graded, and it ranges from a Gleason 6 to a Gleason 10. Gleason 6 being low-risk prostate cancer, and Gleason 10 being high risk. The higher the aggressiveness, the higher the chance for recurrence. Now, that is not a for sure statement, but the more aggressive the prostate cancer is, the higher the chance that it may come back. The most that you can do is make sure you're staying on top of getting the PSA checked in a timely manner. What are treatment options if cancer is found after surgery or post-operatively? You cannot go back in and have another radical prostatectomy, but typically Dr. Patel will refer the patient out to a medical oncologist to establish a plan of care. Going forward, these are some of the available options. There's radiation therapy, hormonal therapy. Sometimes it's the combination of those two. There's also immunotherapy and chemotherapy available as well. To review, PSA should be undetectable post-operatively. Please be diligent in checking your PSA with the schedule we will provide to you in clinic. If additional treatment is needed, a medical oncologist will be a part of your care team to establish what is going to be needed. Moving right along in our trifecta topics, regaining erectile function and the penile rehabilitation therapy. So what is the goal when it comes to our patients and post-operative sexual function? The goal is to get back to a pre-operative erectile function state. Now that is a huge blanket statement. The reason why I say that is a lot of factors go into how a patient heals when it comes to their sexual function. For example, did that patient have difficulty sustaining an erection prior to surgery? Was that patient already taking Cialis or Viagra? Was that patient sexually active prior to surgery? Not to mention how the actual surgery went with Dr. Patel. These are things that need to be considered. Now, after your prostate has been removed, your erectile function will typically not improve beyond what it was prior to surgery. Something else that we don't feel gets talked about enough are any other medical diagnoses that the patient may have that may hinder their erectile recovery, such as cardiovascular diseases, type 2 diabetes, heart and blood vessel disease, hypertension, or high blood pressure. These conditions have to do with impaired blood flow. In order to have a successful erection, you need good blood flow, so having those diagnoses may hinder the patient's erectile recovery. Why do post-prostatectomy patients experience erectile dysfunction? There's post-operative inflammation, mechanical nerve stretching, and poor oxygenation leading to scarring. It's a minimally invasive surgery, but you're still having a major surgery nonetheless. It's a common side effect of having a radical prostatectomy, and it takes the body time to heal from these stresses. That is something I really can't say enough. Your body is in its own healing time, and I encourage you to give yourself grace when it comes to how you're healing and to not set high expectations for yourself, as your body will heal in its own time. Now, I do think it's important to look at the anatomy that corresponds to the nerves that are responsible for erections. I'm going to be referencing the picture that you see on the screen. The prostate gland is in the middle, and it's surrounded bilaterally by the cavernous nerves. Those are those yellow nerves that you see in the picture. Peeling the prostate from the nerves is like taking two pieces of wet tissue paper and trying to peel them apart while keeping everything intact. This is why the skill of the surgeon is so crucial. A little bit about the Da Vinci robot. We just went over the nerve-sparing technique. Now, the robot-assisted radical prostatectomy allows for increased precision in nerve sparing. If you think about the human hand, it doesn't have the range of motion that a robotic arm is able to provide. Therefore, the robotic arm causes less contact to critical structures. The surgeon console is where the surgeon sits, and the surgeon has a close-up 3D view of your anatomy, and it controls the instruments. Those instruments are wristed and move like a human hand, but with far greater range of motion. It essentially translates every hand movement your surgeon makes in real time and bends the instruments with precision. The surgeon has a view of the surgical field that you just can't have with the naked eye. And leading us into our next topic, even with a better surgery, early return of natural function is unlikely if left to heal alone. So what we're talking about here is the penile rehabilitation therapy. This is the regimen prescribed by Dr. Patel to all of our patients to help keep your penis healthy and help you regain your erectile function to preoperative status or as close to as possible. The two components of this therapy are the PDE5 inhibitor medication, so Viagra or Cialis, and the vacuum erection device, or VED. We will be discussing each and breaking them down in depth. Starting with the medication, depending on what you're prescribed, there's a regimen of how that medication is to be taken. Dr. Patel does not believe that one works better than the other. I encourage you to look over your discharge paperwork in order to see all of your options and all the medications that are offered in our educational packet that talks about the penile rehabilitation therapy. Also, please know all of the information we're about to cover on how to take the medication is also written and detailed in your discharge paperwork. Sildenafil, or the generic for Viagra, is prescribed 3 times weekly. Tadalafil, or the generic for Cialis, is taken daily. Now, we prefer that our patients start taking the medication 3 days after the catheter is removed. If you're not able to start exactly 3 days after and start 6 or 7 days after, that is not going to play a significant role in hindering your recovery. Now, one thing I do want to make sure is understood are the additional boost doses that start 4 weeks into you taking the medication. So, for example, if you were prescribed Viagra, that means you start taking it 3 days after your catheter is removed, and you're taking 50 milligrams on Monday, 50 milligrams on Wednesday, and 50 milligrams on Friday. Viagra is prescribed in 100 milligram tablets, and you're able to cut them in half with either a pill cutter or a butter knife if you're comfortable with that. At 4 weeks into you taking the medication, you will start implementing in the boost doses, which means that on Fridays, you will take the full 100 milligram dose. So 4 weeks into you taking Viagra, you will still take 50 milligrams on Mondays, 50 milligrams on Wednesdays, but take the full 100 milligram pill on Fridays. You will continue this regimen for a year. Now for Cialis, it's typically prescribed in 5 milligram tablets daily. For those boost doses, you will take 15 milligrams on Tuesdays and Saturdays, starting 4 weeks into you taking the medication. This means 3 of the 5 milligram tablets will be taken Tuesdays and Saturdays. Mondays, Wednesdays, Thursdays, Fridays, and Sundays, you will still take 5 milligrams. But Tuesdays and Saturdays, you will take 15 milligrams. You will continue that regimen for a year. We will assess your cardiac history to make sure it's safe for you to take this medication, and if not, we'll ask your cardiologist for a cardiac clearance in order for you to be able to take it. General time frame for taking the medication is a year. That doesn't mean it's going to take a year for you to heal. That's just where Dr. Patel has seen the most success in his patients' recovery. Unfortunately, many commercial insurance plans do not cover these medications, so we encourage our patients to shop around and see what options work best for you. We do give our patients a GoodRx coupon or a GoodRx card to use at their pharmacy of choice and to be able to bypass their insurance company. That way, all you'll need is the prescription, that you will get a catheter removal, and the GoodRx coupon or card, and you'll tell the pharmacist that you would like to bypass your insurance. That allows for you to get your medication at a much better rate. I do encourage you to research GoodRx to make sure that you're comfortable in using this option. If you're not covered, or if you choose to not use GoodRx, you may have to pay out of pocket, which is very expensive. So this is why we encourage our patients to look at all of their options. We talked about the medication in full, and now I'll be going over the vacuum erection device, or VED. Later, I will be showing you how to use it so you have a visual to reference. If you have any questions in regards to the VED, please reach out to the contact listed here. This is our medical representative for the VED manufacturer. They can help you with any questions that you may have. First and foremost, you do not have to get the VED ahead of time. When you come into your catheter removal appointment, we will at that time send the VED manufacturer all of your information regarding your insurance and they will be reaching out to you directly and then sending the VED discreetly to your home. Now, before I show you how to use the vacuum erection device, I do want to emphasize some points. You want to add in the VED to your routine 4 weeks after surgery, and it is to be used daily. You will continue using the VED for 1 year, just like the medication, and you can use the VED for intercourse, which I will be going over how to do. Absolutely no intercourse of any kind before 4 weeks post-op. That includes oral sex, masturbation, and any stimulation whatsoever. Before we get into the details of the VED, we want to stress the importance of not acting on any spontaneous or nocturnal erections prior to 4 weeks after surgery. You are not to engage in any form of sexual intercourse, no oral sex, masturbation, or stimulation of any kind until 4 weeks post-op, and that does include using the VED. Before you begin, you will want to ensure that any hair at the base of your penis is trimmed and manicured as to ensure a good seal and prevent hair from being pulled into the device causing you pain. Additionally, you may want to pick up some KY jelly or water-based lubricating jelly to ensure even more comfort when using the VED to place at the base of the penis. Now, the top portion is the actual motor, and it creates the suction. It also houses the batteries. The VED is not waterproof and should never be used in the shower or bath. You'll see 3 different buttons. The plus button, which initiates the vacuum and suction. Pressing it repeatedly will increase intensity. This is low, medium, and high. Most patients either use low or medium. When you press it, you will see a red light and hear the device. The minus button will decrease intensity and also stop suction. However, it will maintain the erection until you press the middle button, which is the release button. It completely enables you to release the vacuum and remove the penis from the pump. This cylinder is where the penis is inserted in the receiving end. You will place the comfort seal like so. Also, you will have a VED band, which will slide onto the cylinder for use with sexual intercourse like so. Now you'll put them together. You'll insert the motor into the cylinder with gentle pressure like so. As we discussed, you will insert your penis into the comfort seal of the cylinder and you'll press the plus button to initiate suction. Increase or decrease intensity to your comfort until you reach an erection that is satisfactory for intercourse or as close to as possible without going further. You will then press the minus button to stop suction and hold the erection in the vacuum for 1 minute. Once achieved, press the center button to release the vacuum and remove your penis. Allow time to return fully to flaccid and then repeat those steps. The goal is to achieve 3 erections with the VED in 1 sitting. It is not necessary or advised to do more than that, as it can have a negative effect on your recovery, and this is to be done daily. For sexual intercourse, you may want to use the VED to achieve and maintain an erection by implementing in the VED band. Now, reminder, no sexual intercourse prior to 4 weeks post-op. As we demonstrated earlier, place the VED band onto the cylinder like so. Initiate the pump to your comfort until you've achieved an erection. You'll press the minus button to stop the pump, and with the VED in place, you'll slide the band down to the base of your penis and snugly secure it by cinching in the white ring. You'll be creating a tourniquet of sorts when you do that. So once you have finished, you will release the band by pulling back the white ring and remove it from your penis. The VED band functions as a tourniquet and therefore cannot be in place on the penis for more than 30 minutes. I do understand that the VED is something to get used to, but it's very important that you comply and utilize it. The VED helps your penile tissues heal and increases blood flow. Now, we do not prescribe the VED for you to be able to achieve an erection, but it should domino effect into that. But that's not the primary reason for why we're prescribing it. We're prescribing it to promote blood flow. The VED also reduces the scar tissue and prevents shrinkage and atrophy of the penis. Atrophy means loss of muscle. So hopefully you can see why utilizing the VED is so important. In tying everything together, you have the PDE5 inhibitors that are vasodilators, and they draw rich oxygenated blood into the penile tissue and help stimulate the neurovascular bundles. The VED has the same effect, except through the mechanical action created by the pump. Dr. Patel feels that the PDE5 inhibitor medication used in combination with the VED gives our patients the best chances for keeping the penis healthy and regaining erectile function. It's important to note that if you're medically unable to take the medication, or if you choose not to take the medication, please make sure that you're staying consistent in utilizing the vacuum erection device. Now, what if the PDE5 inhibitors and the VED are not enough? There are other options available. Dr. Patel likes to exhaust the use of the medication and the VED before we implement more invasive modalities. If you're interested in any of these, I do recommend you either talk to your local urologist or with us to see if you're a candidate for these treatment options. Now, with all of that being said, I do understand the sensitive nature of everything that we've just covered, but know that we're here to assist you in the best way possible. I encourage you to be an active participant in your care and let us know if something is not working. That way, we can be proactive together in assisting you to a better quality of life. To review, the VED is used to promote blood flow to the penile tissues. That is our number one goal, not for you to achieve an erection, but to promote blood flow. Utilizing the pump once a day and getting 3 erections or as close to as possible will be integral in your recovery. Please reach out to the VED manufacturer or our clinic to get further assistance on how to use the pump so you're able to be compliant with the therapy. Now, the last topic of the trifecta, regaining your continence and the regimen prescribed to help you regain urinary control. Now, before we get into the rehabilitation, I do think it's very important to understand the anatomy and what happens during surgery. So follow along with me in the picture that you see on the screen. Now, we have the prostate gland in the middle. The prostate is typically a walnut-sized gland, unless, of course, it's enlarged, and it lies below the bladder and in between the bladder and the urethra. The urethra starts at the bladder, it runs through the prostate, and then continues through the penis, allowing urine to exit the body. When Dr. Patel removes the prostate, there is a gap that's created between the bladder and the urethra. He carefully pulls down the bladder so that the bladder and the urethra can be surgically reconnected. If you wondered why you had a catheter in after surgery, this is exactly the reason why. That reconnection between the bladder and the urethra needs that time to heal. Now, the greater the size of the prostate, the bigger the gap, and this can make it more difficult to reconnect the bladder and the urethra. Now, there's 3 layers in a male that help hold back urine. The internal sphincter muscle that involuntarily controls bladder output, 2 lobes of the prostate, and the external sphincter muscle. Following surgery, you only have 1, the external sphincter. The remaining sphincter is able to do all the necessary work to give you urinary control, but it has to be strengthened. This is why Kegel exercises are so important both before and after surgery, as incontinence is the most common side effect of having a radical prostatectomy. So how do we get you back to urinary continence? Kegel exercises. Kegels strengthen the pelvic floor muscles that control your urinary continence. First, you want to make sure you're locating the correct muscles. So what you can do is stop and start your urine stream. Once you've located the correct muscles, you can move on to actually utilizing those muscles and doing Kegel exercises. The best way that we've learned on how to explain how to do Kegel exercises is through a hypothetical situation. Let's say you're in a crowded room and you need to pass gas. Now, you don't want to embarrass yourself, so you're trying to hold back that gas. When you contract the anal sphincter for 3 to 5 seconds, that is 1 Kegel. You want to work in sets of 10. So when you first wake up, you do your first set of 10, a couple hours go by, you do another set of 10 until you reach around 50 to 80 Kegels per day. That is 5 to 8 sets of 10 per day. If you become sore in that area, just decrease the time that you squeeze. You may have overworked the muscle, and that is okay. It's just letting you know that it needs a break. Please remember that patients are encouraged to do Kegels up until the day of surgery, and after surgery, Kegels should begin 7 days after the catheter is removed. Pelvic floor rehabilitation. So this is a referral that you will be getting at your catheter removal appointment. Pelvic floor rehab begins 2 weeks after the catheter is removed. If you're not able to get an appointment right at 2 weeks, that is okay. Just make sure you're doing your Kegels up until you're able to see your pelvic floor therapist. Pelvic floor therapy is outpatient physical therapy that focuses on improving the muscular strength and blood supply to the external urinary sphincter. Now, our office or Dr. Patel does not determine how many sessions of pelvic floor therapy you will have. This is something that your therapist will determine once they see how much leakage you're having at your first pelvic floor therapy appointment. Dr. Patel has found that this therapy assists in reducing the amount of time that many patients may experience post-operative urinary incontinence. To review, doing Kegels and going to pelvic floor therapy is what we strongly recommend to all patients in order to assist them in continence recovery. Now, what if Kegels and pelvic floor therapy are not enough to regain continence? There are other options available. Remember that these options help with the symptoms that come with having urinary incontinence. They do not cure urinary incontinence. I encourage you to either talk to us about these options or with your local urologist. Some tips and tricks after the catheter is removed. First and foremost, you want to avoid bladder irritants. Bladder irritants are things that are acidic on the pH scale. For example, orange juice, alcohol, coffee, even decaf coffee. Their acidity is very irritating to the bladder. It'll make you want to run to the bathroom rather than walk. So during this time, you want to avoid bladder irritants as much as possible. We're not saying you can never have them again. We just don't want you to take 5 steps forward and 10 back when it comes to your continence recovery. Next, wearing darker pants. This is just so if you do happen to have an accident, it's not as readily seen in black pants versus lighter or khaki pants. Now, wearing briefs instead of boxers, that goes hand in hand with utilizing a full undergarment. When your catheter is removed, we do not have any expectation of you having any control of your bladder. We know that it's going to be a work in progress, and Dr. Patel advises patients it can take anywhere on average from 6 to 12 weeks for continence recovery. We do supply our patients with a couple of undergarments or depends to take home or back to their hotel. Now, wearing briefs instead of boxers, this is because boxers are a little bit too loose, and wearing briefs really help hold everything together. Lastly, discontinue the undergarment when there's less than a tablespoon of urine. This is very important and something we see frequently. The undergarment is there as a training wheel because we're retraining the bladder on how to go about a normal urinary elimination pattern without the prostate. Once you see that there's less than a tablespoon of urine, try not wearing the undergarment at home. What you can do is use a liner if you want, in case you need some protection against leakage that you're having. We've talked about the follow-up appointment after surgery several times. It happens typically 4 to 6 days after surgery. So first, a cystogram is completed during your appointment, followed by possible Foley catheter removal pending the cystogram results. So the cystogram essentially takes a picture. It's an X-ray of where the bladder was reconnected to the urethra, and it will allow for Dr. Patel to see whether or not the catheter can be removed safely. The pathology report will also be explained at that time. During this appointment, we will discuss erectile function and urinary continence. We will also go over all the necessary prescriptions for your post-op recovery and when your next appointment is with us. You'll receive your PSA prescription to check your PSA for the first time after surgery and a possible pelvic ultrasound if you had a lymphadenectomy during your surgery. So what to expect after catheter removal? First and foremost, we want to make sure that you're drinking plenty of water. It doesn't always have to be water. It can be Gatorade, Powerade, but we want to make sure that you're getting your main hydration from water. So we're recommending you drink 6 to 8 17-ounce bottles of water per day for the next 3 days. We do ask that those patients that live more than 2 hours away or at 2 hours to stay overnight after the catheter is removed. The reason for staying nearby is if you happen to go into urinary retention. It's about a 5% chance that any patient will go into urinary retention the first night that corresponds to the day their catheter was removed. Most urinary retention is diagnosed when the patient is going 3 to 4 hours without any urinating into the toilet or any dribbling or dripping of urine into the undergarment, and the patient is also drinking the amount of water that we're recommending, but still having the sensation that they need to urinate and nothing is coming out. If that is the case, another catheter has to be placed back in. This is why we ask for you to stay nearby. A few important items to know. After the catheter is removed, you can resume operating any type of machinery. That includes golf carts and tractors. You cannot operate any type of machinery with the catheter in place. As far as diet, once you've had a normal bowel movement, you may return to a normal diet. Remember, the bowels are the last to wake up after surgery. Typically, patients don't have a bowel movement until 4 to 5 days after surgery. So if you've not had a bowel movement, you will remain on a light diet. Please make sure that you finish your stool softener prescription that we gave to you and avoid spicy foods, alcohol, or caffeine for the first 24 hours after the catheter is removed. As far as weight bearing, you may not push, pull, or lift anything over 15 pounds for the next 6 weeks after surgery. With exercise, you will be walking and doing your Kegel exercises. Additionally, you may not swim, soak, or submerge in any body of water, including pools, hot tubs, lakes, oceans, even if you happen to own any of those, for 6 weeks after surgery. Depending on what you're prescribed, Cialis or Viagra, you will start 3 days after the catheter is removed, and we recommend you take the medication prior to going to bed. We're trying to promote nocturnal or spontaneous erections, hence why you should take it before you go to sleep. No sexual activity for 4 weeks after surgery, as we talked about before. Those cavernous nerves need that time to heal. If spontaneous erections occur, please do not act on it in any way. You will no longer have the fluid component of your ejaculate when you orgasm, but generally patients will retain sensation and mechanism. You also may leak urine when you orgasm. This normally lessens as you go to pelvic floor therapy and do your Kegel exercises. This will help strengthen the pelvic floor and help with any leakage during orgasm. Lastly, you may have a burning sensation when you urinate 2 to 3 days after the catheter is removed, due to the fact that the catheter may have irritated the inner lining of the urethra. If the burning lasts more than 3 days or worsens, please let us know. How to get in touch with a provider. We have on-call physicians 24 hours a day, 7 days a week by calling the office number and following the prompts to reach the on-call physician. The on-call physician can be reached before the hours of 8 a.m. and after the hours of 5 p.m. Eastern Standard Time, Monday through Thursday, and before the hours of 8 a.m. and after the hours of 1 p.m. on Fridays, Eastern Standard Time. If you have any surgical concerns such as unrelieved pain, nausea, vomiting, no bowel movement after 5 days, a fever over 100.5 Fahrenheit, or your incisions are oozing a pus-like liquid or are red or warm to the touch, your legs are swelling up, or the urine is not draining, please contact our office. Lastly, if you have profuse amounts of blood coming from the penis, definitely reach out to the physician on call. If you call during office hours, your message will be transferred to the clinical team. We do reserve the physician on call for emergencies, so if your question can be answered during working hours, please contact us during that time. If you're having any acute changes in condition, such as chest pain, shortness of breath, fainting, you're showing signs of a stroke, please call 911 or report to the nearest emergency room. These are considered emergencies and need to be addressed as soon as possible. If you happen to go to the emergency room at any time, especially if it's not an Advent Health location, once you're stable, please call or have one of your family members call to let us know so we're able to be a part of your care team. I want to talk about blood in the urine. Blood in the urine, a pink tinge to the urine stream, is normal to see after surgery as long as the urine stream goes back to clear or yellow. If you're having a constant stream of blood without it going back to clear or yellow, please call our office immediately. When you come in for an office visit post-operatively, these are some of the things that we cover with you. During the visit, we'll have you fill out a questionnaire that addresses urinary incontinence and a shim questionnaire that addresses sexual function. At the time of this appointment, we'll take a urine specimen and we'll go over your PSA results that you completed prior to that appointment, as well as possible pelvic ultrasound results if applicable. To end off the presentation, I do want to go over what is the GRI. The Advent Health Global Robotics Institute provides the most sought-out robotic surgery treatments in the world. The program is led by Dr. Vipul Patel, in addition to some of the most experienced robotic surgeons in the country that use the Da Vinci robot for other procedures. Dr. Patel has a section of his practice that focuses solely on research. The GRI research team reports on outcomes information used to monitor and improve the quality of patient care. They develop research protocols to conduct clinical research studies and also publish findings in peer-reviewed journals. How does GRI interact with you? You may be asked to be part of a research study, but what we always have is our GRI research team that reaches out at different time points after surgery. We do this to keep communication between the patient and our office, also to check in if we haven't heard from you in a while, or if you're following up with your local urologist. You, of course, do not have to participate in any studies or answer any questions, but your participation in our research is greatly appreciated and helps our future patients as well as our ongoing battle against prostate cancer. For an appointment, please feel free to reach out to our office at the number that you see on the screen. We're also on the web, and for those of you that are more social media savvy, we have a Facebook page and an Instagram if you're interested in seeing what is going on in the practice or what recent publications Dr. Patel has had. With that, I conclude this presentation. Thank you so much for watching, and I hope this gave you more insight on what to expect after the surgery. Thank you so much for being here with us today, and remember, you can always watch the class again as it covers a lot of information. If you have any questions following this presentation, please feel free to call our office. It is also the number that is listed on your blue bag. Thank you again for choosing us to be a part of your care.